Today's healthcare system, and it's been developing for years, is based on fee-for-service. The more services that are provided, regardless of patient outcomes, the more that the enterprise or the provider gets paid. All of these incentives are attempting to change that. And it's attempting to change it by introducing all sorts of measures to measure outcomes and pay providers based on outcomes, so that providers have more requirements, they're getting paid less, but the systems are not available to help them cope with the additional complexity. So enterprises and providers are getting an entire set of unfunded mandates and requirements at the time where we're trying to squeeze the cost curve down without addressing the problem of the uninsured. Physicians especially are among the most highly trained knowledge workers in the world. In fact, if you put a physician in a room with a flashlight and no computer, they can treat the patient. The lights come back on, the computer's there, the requirements are in place. Now they have to code for ICD-10, CPT, DSM, LOINC, RX norm, SNOMED, meaningful use. All that stuff is new. Our system pushes the information to the provider relevant to the exact clinical condition of the patient, so in terms that they understand, with all of that mapping and complexity hidden in the background, we can now, with the MEDCIN Engine and Quippe, put the information that providers want for virtually tens of thousands of clinical scenarios in front of them, browser-based, stateless, in the cloud, immediately. The next step is, can we have that engine adapt to the specific clinical needs of that provider for that patient? So that, for example, we have an index for asthma, prompts symptoms, history, physical findings, tests, therapies relevant to asthma, family histories, etc., brings it right up. But what if I'm a pediatric pulmonologist in Covington, Kentucky, in the downwind plume of an aluminum plant? I always want to ask about aluminum exposure because it might mimic asthma. We don't want to add that for everybody worldwide, but because our MEDCIN data engine is present and available at the point of care, we can monitor that and say, this provider happens to want that item. He searches for it once or twice, and the engine will adapt to him, so the next time, he doesn't have to look for it. We call that PACE, the Personally Adaptive Clinical Environment, which we'll be coming out with late next year. When it came up that what they want to do is coordinate care between, from basically the moment somebody comes into a healthcare system to well after they leave it, in order to minimize the number of trips they have to make back in, that means you have to coordinate between physicians, pharmacies, labs, nurses, other therapists, allied health people, home care workers, etc. We started about 5 years ago to build that kind of content in and integrate it with the physician engine. So we're ready, and our launch partner here at MGMA, Med3000, is using our Quippe product with the MEDCIN Engine to really get ahead of the curve on that. So we're actually pretty excited about it.